All right, well, welcome everyone. Welcome to the Physiatry Mentors. I'm Dr. Sheena Buba.
I'm Dr. Benicia Williams.
And together we are Shanisha. And today we have a special guest, Dr. Aslan Tariq. He is actually one of the first physiatrists to see that there was a need for setting up PM&R electives for medical students during this COVID pandemic. So we'll kind of go into a little bit of detail about what that entails, how his electives are doing. And then also he has a very diverse private practice that he'll go into as well and kind of give some advice to graduating residents. So thank you so much for joining. Welcome.
My pleasure. Thanks.
Thank you so much. We really appreciate you taking the time out. So Sheena and I, we kind of got together, I believe it was towards the end of February, early March, and we foresaw that there was going to be a gap in medical education for people interested in PM&R. So we decided to come up with, the virtual mentoring, physiatry mentors. And you definitely have done a great job. It seems like you foresaw something very similar happening. So we want to hear a little bit more about that as well, about yourself. Tell us where you're from and tell us a little bit about your educational background.
Sure. So we'll talk about myself first. I grew up in Pakistan. I was 18 when I moved, went to undergrad in New York. So I'm a first generation American. Did medical school in Florida, became an osteopath. Like, I think both you guys are osteopaths. I can't remember if you are or not.
I am. Sheena is allopathic.
Sure. Regardless, then I went into doing a fellowship residency at Marion Joy Rehab Hospital. It's a freestanding 150-bed hospital, acute hospital in Chicago, outside of Chicago, actually. And then did a fellowship in sports and spine. But to kind of back up a little bit about like why I picked PM&R, I actually was lucky enough to get exposure in brain injury as a counselor in an undergrad. A job just landed. It was a summer job. I decided to do it. Ended up loving it. Ended up, falling in love with the disability, profession and taking care of people with disabilities. And then that kind of led me to being an osteopath, and then got into residency with the intention of, doing brain injury. But halfway through residency, I realized that even though I loved the patient population, I loved the whole aspect of care for those patients, but I loved sports and spine more. Initially, I thought I was more into interventional pain and, I love procedures. So, to fill the gap in my residency, I decided to interview all over. And actually, one of my favorite practices was Desert Sports and Spine. I know you guys had them over a couple of weeks ago. And, I interviewed Furman and a bunch of, programs out there, got to meet a lot of the top people, ended up doing a academic PM&R non-ACGME fellowship. But halfway through fellowship, I realized that I didn't want to do interventional pain all day. I wanted more of a sports medicine kind of practice. And I got the right skills in that kind of training with the injections and just being, more comfortable with fluoro, more comfortable with diagnosis, imaging. But I realized that my patient population I really prefer to take care of are either general rehab or their sports. I think everybody kind of like figures out what they like to do as you go on your career. So that said, majority of the attendings that I was talking to by the time I was finishing residency, were really not pro working in the SNF setting. We'll talk about that later on. Also weren't really pro private practice and said, it's really difficult. Is it possible? And I'm kind of, a little brave about that and a little more gutsy than people that I know. And I said, I'm going to do my own thing and see where it takes me. If worst comes to worst, I'll get in my own job. So I interviewed at a bunch of practices, ortho spine, ortho only, PM&R, academic, non-academics, to kind of see what's out there. But the kind of personality that I have and the kind of control that I wanted in my patients and population, I felt the best route for me was doing my own independent practice. So we'll talk about that hopefully later on as well, what kind of setup I have. As far as the virtual rotation is concerned, so since I graduated fellowship in 2013 approximately, I've had students with me, since then I have, pre-meds and meds and residents, and I've taught in a bunch of residency programs locally. So I've been exposed to getting myself exposed to teaching on a regular basis. But I was on Twitter for a while, but one of the students that is probably on the call right now, Raghav, he said, hey, you got to come on Twitter. It's like the med Twitter world is amazing. Because I told him to get on LinkedIn. I told him to get on other, medias, but I really didn't even know that med Twitter existed, honestly. And usually I just use it to follow some, athletes and, NBA news. But, as soon as I got on, I was shocked by the number of attendings who were involved and the students who were seeking for help. And I felt like there was something that I had to do. I'm in a position now in my career that I have the ability to help people. I'm not saying that I didn't have it before, but, with the number of doctors that are, in our group and the resources that I have, I felt like I had to do something. And then obviously seeing you guys do it, I was like, obviously like this is what, charity and volunteering is, getting encouraged by other people doing it. I saw you guys, doing what you're doing and other attendings that said, the least I could do is set something up. And there was obviously a need for that. All of a sudden, all these students had lost their rotations. And so that's what got the ball rolling. Initially, I was like, maybe you might have 5 or 10 students might be interested. I sent out that survey and we had close to like 80 students interested. So it was absolutely insane the amount of need there was. The hard part of that was sorting out who needs to start when, and thank God I had help. I had a couple of students helping me out and, sort out who needs a rotation when, talking to medical schools to approve it, what months they have it, how many students, where are they going to be, how are we going to actually do this virtual rotation? They're not actually getting, patient to, student contact. They're not getting hands-on. Like, do they get enough exposure? So I had to step back and start thinking that, if I was to design a perfect rotation, what would that be? And consider the limitations we have right now. So the perfect rotation for me, and we can talk about it later if you want to, is going to be as wide as possible. So seeing inpatient, interventional, outpatient, and getting didactics. So it's a combination of those things. And then, as much as possible, getting patient interaction, direct interaction versus like just, being a student in the back and just watching. And also getting them exposed to the business of medicine, stuff about contracts and what's ACO, what is peer-to-peer. I mean, as a student, you have no idea what those are. Talking about what is billing, what's what do you have to know about marketing? How do you set yourself up? What kind of fellowships do you apply to? I mean, some of the students are on the call and, they can hopefully will give feedback on what it's like, but I designed it as broadly as possible. And then, that's where we're at now. So we're almost the end of the month. There's 1 week left before the first batch finishes. And my initial thing was that I wanted to have the students who did not have a rotation or students who only had one elective that was canceled, because they probably will never get a chance again, possibly, to have first dibs. So that's how it started off. But then thankfully, a lot of schools have started opening the rotation spots and they can actually do it in person now. So for me, like, that's perfect. That's what I wanted. I wanted to help bridge the gap in which students had nothing to do and they had one elective and they needed PM&R. And a lot of them actually were interested in PM&R for years, but they were waiting for that one elective to get that exposure. So I'm able to help a bunch of people out. There's 5 in this group. There's going to be 4 or 5 in the next group, probably the same in the next group after that. So that's where we're at.
Good. Well, you took my next question.
Sure.
You read my mind. So yeah, it was really, I was looking on Twitter and it was almost exactly 2 months ago when you posted about, asking who was interested in doing this. So I'm just curious about the attendings. Are they people that you work with, or did other attendings just around the country volunteer and kind of step up? And how exactly is the rotation kind of set up? Like, what would the student do?
Yeah, everybody's a volunteer. And again, not having set up a rotation before, especially a virtual one, having the number of people, I didn't know what kind of barriers we would get. Mm-hmm. Didn't know what kind of what time commitment, cost commitment. Obviously, with prior practice, you have limited amount of time to begin with. And then I'm not an academic attending who just gets the salary. It's all based on my production. That's right. What I am. So, but regardless, it was tough. And, knowing what kind of tech we need, what kind of platform, is a Zoom, who's going to carry the camera around or the tablet around, what kind of feedback do the students get, timing. I mean, there's so many different dynamics in that. So I'm thankfully with my student, with my skills, that kind of stuff, we will figure it out. But with the rotation, initially, I gave a talk in the very beginning. I had a bunch of students show up to give the intro about the rotation. And at that point, majority of the attendees that I was talking to, this is back in like May or late May, I think early June, the attendees that I was talking to that I wanted them to get exposed to, at that point, they were actually saying that, we were happy to do this, but if you're talking about us dedicating 4 to 6 hours a week teaching students, not just a typical way of doing it, there potentially should be some kind of reimbursement. And that was kind of a tough thing. And then, I obviously switched over and I found attendings who were willing to volunteer their time, like you guys are doing on a Sunday evening. And I switched over and said, I need attendings who are able to give whatever they have, because, students are not going to be able to afford. And, it feels really weird to ask students, especially to give money on a time which, they don't have any money anyway. And it's kind of not a good scenario. But anyway, we were thankful enough that people were able to donate to get us the iPads and the accounts and whatever resources we need. It wasn't a lot of money anyway, but regardless, we would help out. Yeah. So the rotation was completely free. That said, the rotation is set up with my practice 1 day a week, the sports and spine practice. They get to actually interact with the student, a patient. So the camera is taken inside the iPad and they get to talk to the patient, ask history. They present that to me. In the meanwhile, I have them write notes so I can give them feedback on what a good note looks like, talk about some billing stuff as well. They get to see me examine the patient, talk about different maneuvers. Then majority of my clinic, usually I do injections the same day as the visit. So might be a trigger point, might be a steroid injection, PRP. They get to see a lot of regenerative stuff as well, Prolo, PRP. Then we talk about the patient like a normal rotation would be, but in this case, you have 5 students. That's 1 day a week. 2 days a week, they do inpatient subacute rounds with my colleagues. Then 1 day a week, they do interventional spine, who's just high-level procedures, RFA, stims, that kind of stuff, epidurals, facet jaw blocks. And then 1 day a week, we have didactics only. So that's about 4 to 5 hours of didactics only. And the way that is led is we have 2 guest speakers every week. Usually, like, for example, we had someone did gait analysis for prosthetic orthotics, spinal cord, business of medicine, PM&R's history, what else we do? General rehab as well, kind of a mixed bag of things. Then I give a talk as well. Then I have each of the students give a presentation, like I'm sure you guys do in your clinic as well. But every week they have a topic. And the way that I've done exactly the way that I would want it is if you see a patient with interesting diagnosis, I kind of assign them that this is your patient, so this is your topic. They present that. And because we're making this into a study as well, we're going to hopefully get this published as time goes on. We had a pre-rotation quiz to kind of see their general PM&R knowledge. We'll do it after the rotation. And, this could be a concept that can be used in the future, I feel like, especially with international students or, but, if someone is in California and they want to spend time with you, why shouldn't we be able to do that, And one of the things I was concerned about was that medical schools would come out and say, there's no way we're going to approve this. Surprisingly, they're like, yes, we've been looking for this. Can you become a faculty for us, like being an associated faculty? So that was kind of shocking for me because I figured they'd say virtual rotation, you might not get enough education in that, but it was the opposite. They said, we actually want to send you more students. So, I took that as a positive thing, and hopefully that expands on, but that's kind of that. I said a lot.
So how many students do you have right now that you're finishing up your first month? And then are there any kind of changes you would make for the next month? I definitely think you should write up some kind of guide how to do this as well, because I think a lot of places just need to know how. I think it's fabulous what you're doing.
Yeah. But thanks. It's 5 this month, probably about 4 or 5 next month as well. And it changes. And again, it's all based on need. If there's a student who's like, well, the hospital's not letting me, they decline my rotation. And if they get accepted, I said, that's fine. You go do your rotation. I think nothing beats in person. You can't beat that. But this is a really good second option. As far as what I would change, maybe give them more diversity in the rotation. Again, because I'm not academic, I don't have academic hospital privileges, and the hospitals, the people that I've talked to, my colleagues who work in the academic settings, they tried to get the rotation going, but they couldn't get approval from their administration.
A lot of bureaucracy. Yep.
A lot of bureaucracy. Yeah. And even outpatient practices said, we can't, our legal team has said not possible. Mm-hmm. So I would love to expand it to maybe add peds in there, maybe, spinal cord as well. But with my inpatient or subacute practice, we see enough of everything else except peds.
Yeah.
Otherwise, they've seen athletes in my clinic. They've seen chronic pain. They've seen all kinds of diagnoses. So it's pretty diverse. I wouldn't change that. Yeah, that's the only thing I would change so far.
Yeah, I think this sounds like an awesome rotation. I would be so excited if I was a member.
I'm like, how can I sign up for that? I want to spend a day in the clinic with you.
I know it seems like you're taking it month by month based on, the need, but how far, do you think that you're going to do this for? Like how many more months?
Yeah, I was talking to some of my internal medicine and other colleagues that work in that setting, and they're like, how are you even doing this? And why are you doing this? First of all, like, what are you, Mother Teresa? Like, what is the reason for this? And honestly, for me, like, it feels great to help people out. And I'm sure that's the way with you guys,
We got to train them up.
For me, like, it was about, pass it forward, pay it forward. The reason that I am who I am is because of the attendings that I spent time with and I interviewed with, and I wouldn't be where I'm at if I didn't have help. There was no way. I'm a first generation immigrant. None of my parents are physicians. So I'm only who I am because of people that I've helped out. So it's the same exact, desire that I need to, it's a mission of mine to help, students to become better physicians, or, it doesn't matter if they do physiatry or not, but better. And I feel like, you guys obviously did academic and, accept the fellowship, with you, Sheena. The big disconnect between academic and when you go to private practice. And I feel like, and it's hard to know for sure, you guys can say about this, like, is it intentional that the academic or academia does not teach the students how to be private practitioners? So they want to keep everybody in-house. Is it intentional? Or is it just because they don't know, or they're comfortable in where they're at? But I think
it's a combination of both, right?
And I think it's a disservice for us to not teach the students how to practice independently.
Right.
So for me, if I can have students see that I can do what a lot of them, they end up telling me the same exact thing, just like you probably did. I want to start up my own practice, as medical students. I want to have my own office. And then as soon as they hit academia, they're like, that seems too difficult. It's impossible. It's not though, and you guys are examples of that. It's work, but it's not impossible. So anyway, that's kind of the reason I want to keep on giving that, whatever I've learned, my mistakes. Like, you don't have to make the same mistakes, but if you did, it's okay,
Right. I think we're definitely all peas in a pod. Very much similar mentality, right?
Right.
What about, are there any spots available for students who maybe are still looking? Are you still taking students for your rotation?
Yeah, I am, but it's gonna get, I don't know. It's hard to know for sure how long I'm gonna continue this.
Yeah.
It's taking a lot of time, and and I love donating my time and doing what I can, and I'm the kind of person that I'm sure you guys are the same way. I'm all in. I'm not gonna basically have them spend time with other attendings or not give them talks, and just that itself is taking me about 6 to 8 hours a week. That's a full day of work.
Right.
So that's coming out of my family time. So would I want to continue this indefinitely? Probably not. As soon as I can, I'm going to get students back in my clinic. But that said, it's hard to know. But, at least the next 2 months we have. So after that, it's hard to know.
No, that's wonderful. So we will switch gears a little bit. You kind of talked about being in private practice and how PM&R is very diverse. I have a very diverse private practice, as we all do. Tell us a little bit more about your practice.
Well, I saw your schedule. I think it was on Instagram or somewhere. I don't know where it was, or maybe YouTube. Like, you had your schedule.
Yeah.
And I don't think you do the same thing every day. Like, I don't think back to back you have the same thing.
Literally every day is different. Yeah.
Yeah. I don't know how about you, Sheena. You have a kind of similar practice, or I think you're mostly.
No, so mine is mostly like sports and spine, mostly spine, EMGs, injections. Yeah.
Sure. My practice, I don't do the same thing every day. It's so diverse. I don't know if it could be any more diverse than this. So example, I do sports, spine, regenerative medicine. I do medical legal, which is IMEs, life care plans, personal injury, work comp, depositions. That's all part of the, med legal, which I love med legal. Because usually, especially if I'm an advocate for the patient and trying to help them, get what they need, you can't beat that. I don't do malpractice stuff. I don't do a lot of other stuff, but that I definitely do. Then I do the subacute rounds. So subacute, we will talk more about, is basically a huge unmet need of patients out there that really need a physiatrist, but they don't have. So I definitely do subacute rounds. Then I do admin. So I'm the chief medical officer for a company. So 150 of providers that we have across 30 states. So I'm kind of managing all the clinical protocols and coaching and teaching, and pretty involved with PM&R. I'm in the brand expansion committee, which is an awesome committee. One of you guys hopefully can get on it because you're so passionate about this. It's like a perfect fit for you. And what that committee is expanding the brand of physiatry, and how can we change the mindset of whoever is most responsible for the healthcare system right now. And who's really responsible for the healthcare system really is the payers and the policymakers. Doesn't matter if every single patient wants a physiatrist. If insurance doesn't cover it, then they're not going to go see him. So, changing the mindset, we're actually more of doing a ground level thing to talk about the next 20, 50 years about PM&R. So how do we get integrated into medical school education, to the PAs and NPs and kind of on and on. So I mean, I'm involved with that. I'm involved with CMS quite a lot, a lot of meetings in Baltimore. And then, I don't know if I'm missing anything else. No, teaching as well. So, it's a combination of things. I mix it up pretty well.
Yeah, you don't ever get bored, that's for sure.
Forgot one thing. I have a business. I forgot about that part. So how could I forget? So you will love to hear about my business. And I think almost every single physiatrist I've talked about this, they're like, oh my God, that's like my dream. So in my clinic, let me tell you about this. My clinic, I have 4 or 5 offices. I'm sure you guys have, similar or probably more. It's me. I have a chiropractor, a functional medicine physician, an MD, and we have a personal trainer. And the personal trainer does what's called medical fitness. So it's prehab, it's post-hab as well, post-surgical hab. Someone comes in for knee pain, and I know that that's what their main issue is. Oh, I forgot, we have a nutritionist as well. So I have them talk to the nutritionist, get personal training for a while. And if obviously pain is inhibiting what's going on with them, then I'll treat that. But typically it's because they're overweight or functional issues or biomechanic issues. So of course, if they need therapy, they get therapy, but a lot of times training is what they need. They have to learn or teach them how to use their body or move their body. So the trainers are under my supervision. So I manage all that. And then it's a really good way of getting referrals, obviously, because everybody ends up seeing their own patient population and they come and see me for expertise. And it's all under the same roof. So we all get to talk to each other. So that's a big part of my practice. So
that's awesome. I love it.
Like, Benicia, we talked about that, like having a compound where like everything is all in like one place, right?
It'd be amazing. It would be amazing.
I'm curious when it's like that, we always hear about like, what's it called? Oh my gosh, Stark Law and stuff like that. Is that an issue in a practice like that?
Not necessarily, especially if you're not getting any kickback. That's what it is, right? So if they're all independent, then there's no issues. Like they're not paying me rent based on how many people they send me. There's no like connection to.
Right.
They have patients or clients, and it's basically like being in a practice when you have ortho and you have PM&R and you guys go back and forth between patients, exact same thing. Mm-hmm. So yeah, it usually is the Stark Law is when you have like, you have a kickback from any service someone gets.
Right. Yeah. All right. So you mentioned, subacute rehab, and you haven't named the company yet, but it's Integrated Rehab Consultants, and I know you're the chief clinical officer there. So how did you get involved with that group? And I know there's probably some residents, some graduating or PGY4 residents that may be interested in subacute rehab, inpatient rehab. So is this a good group to kind of start off their careers with?
Sure. Well, I'm going to ask you guys a question if you can answer this. Try to guess how many physiatrists in the U.S. at the current moment are doing subacute rehab.
Oh, gosh.
Random guess. It's kind of hard.
300.
You have a guess, answer, Benicia?
I would say something like that, 300-400.
1,000.
Okay.
Yeah, and that does not include.
Yeah.
That does not include the NPs and PAs who might work with them.
That's
only
wow,
okay. So you're probably talking about 1,500 or more. Maybe less than that, but approximately that number. Obviously, you have 8,000 physiatrists. So, there's a lot of subacute, obviously, physiatry out there. As far as the number of patients who are currently or over a year, they get acute rehab is about 300,000 in the U.S. And there's 1.6 million patients who get subacute rehab. So more rehab, 5 times more rehab is happening in the subacute setting. So why are 10 times more physiatrists in the acute setting? So, and it's because it's changed, it's different from when I was in residency. So when I was in residency, and I'll talk about subacute, but when I was in residency, we had a subacute unit in our freestanding rehab hospital. So we saw the continuum of care. We had acute rehab consults, like literally ICU consults, acute consults to get them to rehab, acute rehab, and then transition obviously to go home or subacute rehab. So we would stay as their attendings. Then they would have outpatients. So you had the whole continuum of care. There's no like, sorry, we're going to see you in a month outpatient, or maybe in a couple of weeks, or maybe you'll never see a physiatrist before. So there's obviously a need. Our attendings in residency, all of them, they're all in private practice. They're academic with their private practice. They all had subacute practices. This is back in, they started in the mid-90s. So subacute rehab is not new. It's becoming more popular now, but it's definitely not new. But things have changed, obviously, and you probably see a lot of this when you see it, but it's like Insurance companies are denying patient care. A lot of the patients are not qualifying, or they're too sick to get acute rehab and not well enough to go home. All the managed care plans, the bundle plans, they have their own values, what they want to save money on. Regardless, there's a significant need for patients in that setting. And what typically happens is that people go to the subacute setting and never see a physiatrist, typically never even see primary care. They might see a nurse practitioner, maybe. And what does that do? Rehospitalization goes, hospital care goes up, falls, fractures, disability, deconditioning, all these things. Especially nowadays with COVID, social isolation goes up. So all those things are basically things that Medicare insurance companies are trying to reduce cost in. So that's where we come in as physiatrists. So Dr. Patel, Amish Patel, the CEO of the company that you know, Benicia, he started the company back in 2010. He was my chief resident, and I was the third physician in the company after fellowship. And again, we saw the need. In residency, you guys probably remember, maybe it wasn't for your case, but we had an ortho unit in our residency, in our inpatient rehab with the knees and hips. That unit got shut down while we were in residency. And I don't think I saw a single knee replacement, hip replacement in my 3 years of residency, unless it's a complicated, sepsis, UTI,
or bilateral,
right. Severe obesity.
Right.
So, and that's where the patients are going. So I'm basically our group is following the patients. And the insurance companies at this point are actually demanding physiatry to be involved. It's not even like us saying that, hey, we want to be the physiatrist with the patient. It's the payer saying, no, we see a value in you. That's what we've always fought for, right? We've always fought for someone saying, we love physiatry. And I'm hearing from Anthem Blue Cross is no, actually we want physiatry. So yes, I mean, that's what we want. We want ours to be on the table. We want that the patient population to get the care they deserve. So that aside, that's the patient population. What do I do in that setting? So in the acute setting, obviously a lot of times we're the primary. So we manage their internal medicine issues, their everything, right? So we pretty much are the primary care. We might be reverse, in which in the inpatient setting, we might be the secondary physician, or maybe the physiatrist, but they have internal medicine coverage, kind of a co-management model. In this setting, we're the consulting physician. So seeing patients, following patients twice a week, 3 times a week based on needs, with the same goal: reduce pain, reduce dysfunction, get them home in a safe environment. And the facilities and everybody we partner with, we have studies behind us that show that we can do that. We can reduce health. We can reduce the cost of care. So as a group, we're across the country in certain states, all of us, including Dr. Patel and myself, we're all independent contractors. So we have an umbrella group on top of that, that provides the support, but we're all independent contractors. It's nice because I get to do anything I want. So my clinic is independent, my EMGs or IMEs or anything I want to do. And my practice is based on what I want to do. So someone's like, I really want to do spinal cord. Absolutely, you do that. We have docs who want to do wound care, docs who want to do Botox. I mean, any kind of practice style you want. So there's no one who's telling you what to do or how to do it. We give guidelines, obviously, and you get a ton of support. And, it's very different from the outpatient setting. And obviously you guys both know this. If I have a cancellation, I have a cancellation, that's lost time. Maybe I'll catch up. In the subacute setting, I am going to the facility, so I get to make my own kind of, style or timing or things like that. So it's my work more based on me. So if I round at 8 or 10, whatever time, it's all based on me, just like how you do it in inpatient as well. So I get to go room to room versus waiting for someone to kind of get someone in. So it's very streamlined in that sense. And because we're not the primary care, one of the significant issues that I had with inpatient rehab, and maybe Sheena did, or Benicia probably don't as much, was call and was, internal medicine. I was like, I'm not an internist. I mean, I love it, but I don't want to manage SIADH, and I don't want to manage insulin. And that's just me, not everybody's like that. And
we're like that. We don't want to do it. That is us.
I know some internal medicine PM&R, double board certified docs, but
and they like it.
Most of us, it's because it's not as easy anymore. It's getting more and more complicated.
And we could, when we were in residency, it was second nature, when you got that cold. But as you've gotten out, it's no, I don't want to do that.
You got to manage cancer drugs, and you got to manage
oh God.
transplant medicine. And
I was
I'm
just
like,
the Prograf, right? Exactly. The FK levels. I'm like, wait a minute, this is bringing me back.
I do what I'm good at, which is the rehab pain, and then they do what they're good at. We work as a team. I'm still the team leader, as in, I manage the rehab team. I do bedside injections, ultrasound. I have a portable ultrasound machine with me, the Butterfly, I think we talked about briefly. The students have seen me do it. I just did a piriformis. I do SI joints. I do all kinds of like peripheral joint injections bedside. The patients love it, obviously, because it's someone coming to them doing it versus doing an outpatient. So all that said, the satisfaction I can't beat, the flexibility financially, because you're independent. Obviously, like 70% of your paycheck is not admin, which is usually how it is in academia. So, you live a comfortable life. You don't make interventional pain stims all day kind of money, but you do
well. Yeah, right. Your bills are paid. Right, yep. Exactly. No, I've done some subacute when I, last year, I've been out of subacute maybe for about 6 months. We just left a facility not that long ago, but like even the primary teams that we worked with, they loved having physiatry there. We worked with a nurse practitioner closely. She loved having a second set of eyes. Like, who wouldn't want a second set of eyes? Another physician when they're only there 2 or 3 days a week and you're like there the other days. So no, right. It's what's best for the patient at the end of the day.
Yep.
Exactly. But it had challenges though. Obviously, like every
practice
has challenges. The challenges are that the common saying is that every sniff, if you have 2 sniffs, they're both different. I mean, there's like no comparison. Every single one, even if they're part of the same umbrella group or, part of the same organization, and they might have shared staff, but they all work differently. It's way less organized as a hospital setting. The staff is not nearly as competent as the acute rehab setting. Documentation can be challenging, but in the end of the day, for what I think about is the patients need me. The other challenges, it is what it is. I could be in a terrible country. It doesn't matter where I'm at. Patients need someone to do what I can.
And I feel like orthopedic surgeons are happy when they know their patients are going to a facility where there's a physiatrist. I used to talk to orthopedic surgeons all the time. I'm like, hey, I'm going to send them. This doesn't look great. Or I'll take a picture. This is what I'm thinking. This is what I'm doing. If you want any kind of imaging, let me know. But they felt good sending them to where we were at.
Same. Absolutely.
All right. Should we open up for some questions from the audience?
Yes, please.
All right. We've got a few here. So Shivam Patel says, I've seen a lot of things about ACGME versus non-ACGME accredited fellowships. Yes, we had a good talk on that. Episode 4 is on our YouTube channel. Check it out. On your journey in physiatry, has it made a big difference doing one versus the other? Is there a difference in what they emphasize?
Yeah, we have a whole, like Sheena said, we had a whole kind of hour talk, and please, it's all good. You can kind of tell us what you think, but tell us, you get paid the same at the end of the day for the same procedure.
Right, yeah, and we didn't have any issues with accreditation. So I went to non-ACGME, I went to Desert Spine and Sports Physicians, and Venetia did her sports medicine fellowship at ACGME, fellowship at JPS, and at the end of the day, neither one of us had issues getting credentialed or anything. So, but really check out that episode. It's a good episode. We had 2 other physicians join us. One did ACGME pain via PM&R, one did ACGME pain via anesthesia, and then Venetia did sports med, and then I did non-ACGME. So check that video out. Let us know if you have any questions. All right, Sierra says, what are some things that were important to you when looking for a job, finishing residency and fellowship?
Can you repeat that? Is that what are important to you, or?
Yeah, what was important to you when looking for a job?
I think for me, it was the people who were going to hire me. That was probably the most important thing, because they're part of your family at that point, so I'm sure Venetia felt the same way. It has to be that, that's probably the major reason, because if you
spend a lot of time with them,
right? Because I've heard so many cases, and I don't want to go into, some of them, of people being treated horribly, contracts and, not getting paid or getting fired or, those kind of things, and being mistreated or let's just say, practices that are unethical. That's probably the best way of saying it. And you don't realize that until you show up. Yeah. So if you know someone beforehand, that's the best way to do it. And what I did, that I wanted to stay in Chicago, is I spent a couple of hours with attending, or ortho practice or PM&R practice, whatever it was. I just want to get this feel of this person's personality. And when actually interviewing for jobs, if possibly they can open up their books to kind of show you. It's hard. Most practices are not open to that, and the ones that are, then you kind of know they're transparent and they're fair.
That's exactly right.
Yep.
Right. So if you can kind of see what their peer mix is, what their overhead is, all that kind of stuff. Because if they tell you what it is, it might not be the case until you actually see it. So
right.
For me, that's important.
Totally agree. I think, was it like location, autonomy, pay? What's the fourth? I feel like there's one more other thing. Those are kind of like
doing what you want to do.
Yeah, priorities for it. And I know for Sheena and I, which sounds like it's very much the same for you, autonomy was huge for us to be able to run the type of practice that we wanted to run. So that was definitely a priority for me and then Sheena too. We were looking for our own jobs.
And location.
Right.
And I was personally very biased towards working in the PM&R group. Obviously, makes sense because I had a bunch of my colleagues who had offers to become a partner, on initial signing up, and then 5 years later and 7 years later, and really nothing really happened. I mean, they really never became a true partner. Maybe like you can buy in, but I think as a resident, you don't even think about those things, but you should start thinking about those things. What does that mean? What is a buy-in? Are you buying into the MRI machine, the therapy, and are you going to basically split the overhead? Because obviously surgeons have a significantly higher overhead than we do. And are you going to be a voting partner? Have other physiatrists in the group become partners? How long did that take them? Those are the kind of things you got to think about beforehand. PM&R groups are usually more fair about that because the same specialty, they'll probably make you partners and overhead is lower. But those are the kind of things to think about. Also, like going towards is it a guaranteed salary versus some kind of, based on other, productivity or that kind of things. Those are things I got to think about. We don't have enough time right now to discuss all those things, but those are kind of things you kind of get a gauge of, for practice. And also, one last thing is find out if they have another physiatrist who was in the practice, and if they left, try to talk to them, find out why. That will save you a lot of heartache.
I think that's great. Yeah. And in my practice, there are actually 2 PM&R doctors. So I work with a lot of surgeons as well. So it's a mix, of subspecialties. And the 2 PM&R doctors that were there have been there. It's been their only job since they've come out of residency and fellowship. So they've been there for each of them 10 plus years. So I think that says a lot also about a practice,
longevity.
Well, yeah. And, they really like it, and it's very fair and equal partners and all that kind of stuff. So
it's important.
All right. All these questions coming in, guys. Okay. Shivani says, do you recommend doing a fellowship, or would you have felt comfortable going straight into practice after residency?
Can I answer that? I think you should do a fellowship. It's the one time in your life in which you're already in education. It's 1 year, it's going to go by fast, and it's difficult to go back to do a fellowship. Imagine either one of you, leaving your practice for myself, right now to do fellowship. Nah, I don't think so. This is really, really difficult. I know people who have done that, but it's significantly more difficult. If you think that your residency is going to provide everything you might need, and it's difficult for PM&R to provide such a broad exposure in 3 years, because you got to do inpatient and outpatient and EMGs and ultrasound, regenerative medicine. If you add it all up, 3 years is not enough. For me, it was basically whatever training I lacked in residency, I was going to get that on top. And yes, it gave me the kind of the baseline of what I know, but whatever I've learned in practice is way more than what I learned in fellowship. Sure, it gave me a nice, ground to lay on, but you learn so much even after. I'm still learning. I'm constantly learning. We're both learning. You guys, while you're teaching, you're
every
learning.
day.
But the fellowship is one thing, just get it out of the way. I feel like it's just done. Yeah.
Especially if you want to be more interventional. If you want to do more interventional fluoroscopy, ultrasound, I 100% agree that you need to do a fellowship.
Right. Yeah. Especially getting credentialed at different places, right? They want to know how many procedures you've done, and no matter
you got to present a log.
Yeah. How much hands-on your residency has. I mean, these spine injections, you get better every year doing them. So, I don't think necessarily coming right out of residency, you should be, totally comfortable going straight into,
That's how it used to be 10 years ago, 15 years ago. Majority of attendings just came out, did weekend courses, and that's how it used to be. But now when everybody's applying, anesthesia is applying with the fellowship training, and then you're applying, they're like, no, we're going to have anesthesia do all the epidurals. You can't. And that could happen. So to make your profession or your career more, safe, I think makes sense. And also, I don't know if you guys do med legal, but I do med legal, and the attorneys are rough to work with, because they're going to try to do anything they can to, find faults in your training. But all I have to say is I'm fellowship trained, and that conversation ends. So if I say I know how to, I know what epidural injection is, or I've done that in clinic, and that's it. They don't go any further to saying, is it ACGB or not ACGB? They don't know, or they don't understand the difference, or they might, or they don't care. Board certification is what matters, So those are more important things, I think. But anyway, fellowship, just get it out of the way, in my opinion.
All right, we got two similar questions here from Alvin and Rajab. If you decide to start a private practice right out of residency, where do you get your patients? How do you get the ball rolling? And what factors made you decide to go into your own practice?
Okay, so why don't you answer that if you want, Benita?
I am in a group of 5, so I was very fortunate to join my mentor's practice. So he definitely was the type of person, like, he and my other partners ramped up their practices for me. So when I stepped in, that I took over, I went to SNF, I was doing some acute inpatient rehab, I was doing consult. So these things were already built up. So to do a solo private practice would probably be a little bit more harder, because you won't have someone there to ramp it up how I had it. But it's market. You have to be able to market yourself. You have to hit the ground running, meet these primary care physicians. You have to tell them what PMNR is, what it is you do, what you have to offer, and how you can help your patients. Marketing is huge in private practice, and networking. Every little network, when I first started, every networking event that we had here in Fort Worth, I was at, marketing myself and telling people who I am. Like, no, most primary care doctors don't want to do back pain. I'm like, I'm a back pain specialist. That's my favorite thing to do. So they're like, oh my God, yes. So yeah, you got to just put yourself out there and meet people.
Definitely. And it's not easy. I'm an introvert. I don't like talking to
I'm her wing woman. I'm her wing woman.
So, but you have to do it. And, these are physicians you need to make relationships with in your community, and they'll see, you treat your patients right. They will see that. Other patients will go back to their primary care doctor and tell them, hey, Dr. Williams, Dr. Drake, they treated me really well. They listened to me. And so that's kind of how you get that referral base going. And again, marketing, doing your own, I am fortunate. We have a really big marketing team at my practice. And so they do a lot of stuff. But we also do, Nisha and I do a lot of stuff on our own social media, on our own social medias and things like that. So.
Yeah, my marketing team is me. So I'm not the one. So I think the answer to that is complicated. Depends what kind of practice you have. I think it also is based on location, geography. If you're in a small town, you probably don't have to do it. If you're the only show in town and you're the pain guy or whatever, it's fine. You'll get the referrals because you're the pain guy. If you want to do a regenerative medicine practice, you're probably not going to get a lot of referrals from other providers. It will be mostly word of mouth. It might be online, might be marketing, SEO, talks that you guys might give, seminars, because that's a very different patient population. They usually, is out of network or, out of pocket usually. So very different. Typically I don't get a PRP injection request from an ortho. They're probably going to do a scope. They're probably doing something else. The primary care, they might or might not know about it, might not think about it. But regardless, that said, it really depends on what kind of practice you want. If you want to be the chronic pain guy, you're going to be full pretty quickly, because a lot of the primary practice guys, they want to just give you patients. They want to keep the patients. If you want that perfect sports and kind of spine kind of practice, unless you market a bunch and you're involved with athletes and you're doing weekend coverage or you're doing events and you're part of academic hospital and teaching, you're not going to get a lot of referrals unless it's word of mouth. So with my practice, it was mostly word of mouth, having a number of similar thinking, physicians and providers around me. So I get referrals from therapists, acupuncturists, massage therapists, chiropractors, family members, the Chamber of Commerce. It could be any of those. And once that happens, then, the word of mouth starts going. Then, can you see my aunt? Can you see my uncle? And then next thing you get busier. But the only way I was able to do it is because I had other income sources. If all I did was outpatient regenerative medicine, and, it's impossible to get busy 5 days a week unless I had a team of marketers. So I had the second income of the subacute. Using that and, you know, having diverse income sources makes it a lot easier.
All right, Dr. Salat, our favorite, is on right now. He says, first off, big kudos to Dr. Tariq for helping med students, a man of my own heart.
Omar is my partner and she mentored both of me. So.
And then he asked, am I on a standing desk at this time or am I sitting?
He's for sure at a standing desk. He doesn't have enough energy to, I mean, he had too much energy. He can't sit still. So
I'm sitting right now, Dr. Sloan. I bought my standing desk. It should be here in a couple of weeks, hopefully. All right. And then he says, another good way to get business is to train med students and residents. This is true. Some will go into primary care and they will remember you when they graduate and have a comfort level with you if you taught them and treated them properly.
That is, Omar's so good at giving back, and he is mentored me, obviously, and just has really been a big source of me wanting to even do the virtual physiatry mentors, because he's been such a wonderful mentor to me. Our offices are right across from each other. So.
I've never met him. I've talked to him on Twitter and stuff, but like, I feel like I want to be him, you know?
Oh, we should do, maybe we'll have you guys all on and we can do like a private practice talk or something. Yeah, that would be good.
I can't wait to meet you guys in person at 8 p.m. And I'm there every year.
I know. Yes, we're going to do it.
Yeah, absolutely.
All right, B, should you do the honors? Those are all the
questions. All right.
Right,
so last question is, we asked all of our guests, if you were not a PM&R physician, what would you be? And you can tell us in medicine and out of medicine if you want to.
So just the way that my personality is, I'll probably do both medicine and out of medicine, you know? So I want to do public health. I want to do it for a long time. And my goal was to maybe work at WHO or UNICEF or something like that, because I grew up in Pakistan. I saw the disparity in care and things like that. And I felt like it could make a big difference. But then at the same time, I would love to be a DJ. So specifically a trance DJ. So I don't know. I just love Eurotrance. So.
All right. Well, great questions, great answers. All right. So I guess that's it. If anyone doesn't have any more questions, what is the best way for, you know, if anyone has any questions to reach out to you, how should they do that?
I think Twitter is a good way. I'm happy to, you know, my website is Optimal Health Medical Fitness, OPPIMAL, optimalhealthmedicalfitness.com. You can always call, email from there as well. I'm kind of excited to hopefully start in-person rotation soon, because I get to have the students, you know, do injections and do ultrasound with me and that kind of stuff versus watching it. But hopefully whoever's on it right now is, you know, getting the most they can. And a lot of them actually are rotating after this in the PM&R, you know, a couple of months from now or maybe next month. So I did everything I can to prepare them for that next rotation.
They'll be rock stars on those rotations.
Yeah, I hope so. Yeah.
Yeah. Well, you are doing a great job. I think it's awesome, you know, what you're doing out there for our community. So thank you so much for joining us.
Yes, we appreciate it. I know. We're gonna have our own table. We're gonna do a thing at the next day.
All right, guys, thanks for joining us. You know, you can always follow us on IG, Facebook, YouTube videos. And we'd also like to thank Baylor Dallas and University of Minnesota. So they were the two programs that started off our IG takeovers last week.
They did great.
We have Monday is Western, and Wednesday will be Georgetown. So will be super fun.
It's only water, but cheers.
Yeah. Cheers, guys. Awesome. Yes, all right. We'll see you guys next week. We appreciate it.
Oh, and next week, sorry, before I forget, will be John. Yep, he's a resident at the University of Minnesota, and he's actually doing a lot of putting together a great educational resource for PM&R called Foam, and we'll go into more detail about that next week. So join us then. Have a great week, guys.